All right, thanks for everybody for joining today. You know me by now. I'm your general contractor and host, Mike Krupa. I think you know my background. I'm going to do something a little bit different here at the start of this. We're on episode 5. We have one more left. So there's a chat function. There's a question function. We'll definitely take questions at the end. I want to respect everybody's time. But one thing I wanted to ask the audience, and feel free to answer, is now that we've gotten through most of these, let me know if there's any other topics that you want to hear about personally. Would love to continue this webinar series, and if there's specific things that you would like to hear about or you want some more information on, let your mind go anywhere with that, and feel free to throw that into the chat or the questions, and I'll make sure that I incorporate that. So we have one more episode left, and I'm excited for that last episode because we're going to do a final reveal and a deep dive into a case study of an employer that went through this entire process. But I'm pretty excited to talk about today's webinar as well. You know, we've done a deep dive into direct primary care in episode 2, where we talked to Dr. Alex Lickerman. Episode 3, we dug into prescription drugs, and specifically 3 ways that your employees and members can access their medications for free. And last episode, we talked about how you can add spending limits on your health insurance plan so it does not act like an unlimited company credit card. But today, we're going to dig more into direct primary care. We defined what it was in episode 2, but today we're going to go behind the scenes with a practice that is going to tie everything together, all the episodes together that we've already talked about. And this is definitely something that you need to hear about. But before we get there, I want to do a quick refresh on the remodel health process, and then we'll dig in. So again, just what's the problem, right? We're dealing with a lot of different competing interests within the healthcare space now that are stacked against you. You have insurance carriers that are making money hand over fist, and we're not getting the value out of what they're seeing in terms of their stock price increases. And that has to do with incentives that are baked into the Affordable Care Act. Next, it's this PPO network, right? You got 95 to 99% of all providers are within a network with virtually no tools for employees to be able to determine the cost or quality of a provider up front. So we get this huge price disparity across the board on procedures. And lastly, without having limits on your plan, employees have an unlimited company credit card with their medical ID card. They can basically go wherever they want, and you'll end up picking up the rest of the bill. And that could be a $200,000 bill. And whether you're fully insured or self-funded, that is going to impact your renewal. And for most employers, you know, this problem has led to the health plan looking like the one on the left. It's outdated, there's design flaws that need to be fixed, but worst of all, I can pretty much guarantee your employees do not like it. That was my bathroom a couple of years ago. It was original to the house. We had design flaws that were leading to a leaky shower, and honestly, me and my wife hated being in there. So I started a plan to remodel it, and I got started. I collected a ton of data through the demolition process, and I understood why I was having problems with certain things. And the point is you can do the same thing on your health plan. That means creating a long-term plan. That means collecting data on why certain things are happening within your plan. And that's going to arm you to build a high-performance health plan. And the picture on the right is the final product, and most importantly, the customer, my wife, loves it. And that's one of the things I've stressed and want to continue to stress throughout the series, is that there's a ton of remodeling that you can do on your health plan. But at the end of the day, if you, and specifically your employees, the utilizers of that health plan, do not love it, it will not be successful. And also, if you want to stop being surprised by your health insurance renewals, you have to stop making one-year decisions. And I don't care if you're fully insured or self-funded, you need to create a long-term plan. That's how you're going to start to change things. And then lastly, you don't have to remodel your entire health plan at once. This was one room in my house, and the whole house needed to be remodeled, and we're still working on it. In next episode, we're going to show you a case study of an employer that completely remodeled their health plan. But every employer is different in how they get there. And the employer we're going to talk about, it took them 3 years to get there. So just keep that in mind. And so it's important within the remodel health process, what this does, simple 3-step process. The first thing you need to do is start to get control within your health plan. And if you're fully insured, that means create a long-term strategic plan. That means start collecting whatever data that you can on your health plan. And then ultimately, you need to self-fund your health plan if you want ultimate control. It might take you 3-4 years to get there. You may never get there. That's okay. Stick with that long-term plan. The next step after you self-fund is key, and that's aligning your health plan with partners that have your best interests in mind. It starts with your general contractor or your broker. And the piece of advice that I would give everybody is just understand how your broker gets paid and understand how the partners within the health plan get paid. That's going to lead to what is everybody incented to do. Last step of the process is reward. If you want your employees to love the health plan that you're in and you want good financial results, well, then you need to reward them for making good healthcare decisions. And we talked about a lot of different things. We're going to dig into more of direct primary care today, which is a huge reward because you're basically giving your employees access to free, unlimited primary care. But more importantly, you're getting time. So before I dig in and introduce my guest, just a quick refresh on direct primary care. A couple sentences here, and then we're going to dig right in. So direct primary care, all it really is a change in payment model. Today, every time you go into the doctor, you pay for a service. That's called fee-for-service. In this model, you're purchasing primary care like a gym membership. You or your employer on your behalf would pay this membership fee, and in lieu of that, you'd get free unlimited access to primary care. This payment model creates a very known revenue stream and cuts out a ton of administrative waste. And what that allows a direct primary care practice to do is see 1/4 of the minimum number of patients a traditional primary care provider would see. They're capping their patient panel at 600, and the typical primary care physician is seeing a minimum of 2,400 patients a year. That leads to significant more time with the patient, and that is the secret sauce, time. So I'm gonna introduce my guest now, Rhea Campbell, co-founder of ImagineMD. Rhea, would you mind just doing a quick introduction of yourself and maybe 30-second elevator pitch on ImagineMD?
Sure. Yeah. Thanks, Mike. That was a great overview of direct primary care. So thank you. My name is Rhea Campbell. I'm the Chief Administrative Officer of ImagineMD. We are a multi-site direct primary care practice. We're here in the Chicagoland area, and we serve self-funded health plans. We actually serve self-funded and fully insured health plans, basically functioning as the foundation piece of a health plan that is reconstructed to do two things. One, to help provide better outcomes and experiences for those health plan members, and to lower cost.
Great, thank you. All right, so Rhea, I met you about 3 years ago, and your background was so interesting to me because I think about when humans are stuck in a problem over and over again and we just can't figure out what the solution is. And then you get somebody with a fresh set of eyes, takes a look at it, and boom, solution feels like it comes out of nowhere. And that's what struck me about you and what you do behind the scenes. Can you just explain a little bit of your background and why you probably have a pretty interesting perspective on the U.S. healthcare system?
Yeah, thanks. It feels like it was more than 3 years ago. I just have to say that, though. It feels like it's been a lifetime. Yes, so I'm a Canadian. I actually come from Canada. I've been here for 23 years, but I'm married to a physician who practiced at the University of Chicago. And as such, we had access to amazing healthcare. I actually didn't know what a PPO network was. I didn't know what healthcare networks were. I had never experienced a deductible. I barely even knew what a copay was because, quite frankly, my copay, as long as I got my services, my health services at the University of Chicago, was $20. And I think it just came out of my husband's paycheck. So, like, I never actually, paid any money. So, what happened was, because I come from the Canadian healthcare system where you put out your health card and you can consume all of the healthcare that you want, I didn't know that the American system was actually set up differently. Now, I also have a background in hotel sales and management. So you're dealing with a customer, a guest experience, right? It's my pleasure. How can I help you? And I was, so with that background, we shift over, right, to direct primary care, and we launched this new company, and I get in and I look under the hood of what is American healthcare, and I'm utterly shocked by what I see. But what was really interesting is I had to learn what all of these concepts were from the ground up, right? What is a PPO network? What are networks? Why is Aetna, Cigna, United, why are these different? How is the pricing from one to the other so dramatically different? It didn't make any sense to me. And as such, I was able to see the ridiculousness in how that is set up. Now, many of us as Americans, right, if you've grown up in this system, you don't know how ridiculous it is. That's all you've ever known. So I think that background allowed me to look at all those inefficiencies and just to be to not to accept them, and to also look at those and say, well, then this is what we have to fix, this is what we have to deconstruct, and not to believe that there was a barrier to doing that. I just thought that's what I'm supposed to do. I'm going to understand it, and then I'm going to fix it, and I'm going to create a system from which ImagineMD can refer our patients into appropriate places of service that are appropriately priced.
Great, thanks. And the fact is that the solutions are out there. You just got to figure out how to actually access them. And I think that's what you and your team do best behind the scenes. So I'd like to just have the audience understand, a little bit about your role. I've spoken to multiple DPC, direct primary care practices, and there's a lot of good things with most DPC practices, but you guys do something different behind the scenes, and your role in particular, I think, is crucial into the cost savings component. Could you talk about what you do?
Sure. So I run a team that we call the Healthcare Angels. So the Healthcare Angels are essentially our medical assistants. They support our physicians and our patients. They'll draw blood. They'll arrange for all healthcare services that are referrals outside of ImagineMD, so any specialty care that's needed. They'll gather the consult notes. They'll help to arrange the surgeries. They'll make sure that the patient experience inside our four walls and outside our four walls is smooth. And really what I do is I help to create the systems and some of the technology from which they access and utilize to make sure that the patients, when they leave our four walls, are going to have a good experience. And what's a little bit unique about this is that we have systems in place that do two things, right? These are the only two things that we are concerned with because we are disconnected from fee for service. So we're not worried about making money by, hey, let's get the patient to come in more so that we can bill another 99214. Because as Mike said, when he opened the webinar, this is a per member per month. We don't make more money the more we do to you, and we don't make less money the less we do to you. We are unconflicted in your care. Okay, that's the really important piece. But what our focus is twofold. One, we want to make sure that you're going to the appropriate place of service. So when you need a referral for specialty care, when your direct primary care physician says, this is beyond my level of training, or I need a specialist for this.
Like a cardiologist or dermatologist or something like that?
Cardiologist, dermatologist, gastroenterologist, all the ologists, correct. Yep. Then we will make sure that you are referred to to the highest quality. Now, quality does exist in some areas and not in others. Right now, for example, quality metrics do exist in interventions that get done over and over again, where that they can be measured. So, for example, surgery. How many times does that surgery take place with that particular physician? What are the readmission rates? What are their reinfection rates? What are the mortality rates? How many times do they actually perform this particular type of surgery? Because think about it. You want somebody who is a master at carpal tunnel syndrome. You don't want a general surgeon who does hips, knees, and carpal tunnel. And maybe they've only done 5 carpal tunnel surgeries that particular year. You want somebody who's really good at it. And then the second thing is, well, the first thing is high quality, okay? And we'll look for quality.
How do you determine quality, right? Because us consumers out there that are utilizing a standard PPO network, there's just not a whole lot of tools out there for us to even determine. And I feel like most people, because they feel like that's all they're left to do is like, hey, mom, who did you get your hip replacement from? Or do you know anybody, right? And that's the way people find what they think is a high quality provider, because that's what we're left with. But like, what do you use? Do you have a tool? Do you have a database? Like, how do you determine quality?
Yeah, that's a really good point. So we do have a database, and it is, the data is culled from Medicare. So it's billions of dollars in claims that actually show how many times this particular interventionalist does this particular surgery, and the metrics have been reported. Now, it's not perfect, right? Because a dermatologist that is not performing some sort of intervention, right? You have to rely on our physicians who've had interaction. So now we've got something less tangible, but still quite good, because here's what we use. Do they communicate and coordinate with our physicians well? Do they send us the consult notes in a timely fashion? Are they willing to communicate and consult with our physicians outside of a paid encounter in order to make sure that that patient is going to get and have the best experience and best outcome when they do get there for their 99214, which is the actual claim that they can submit to the health plan. So it's not as data driven, but it is the best that we have. So we combine those two things together when both of them do exist, and we look for top quality if those quality metrics exist that line up with somebody that we've used that we know communicates and coordinates well with our physicians. The second piece, let me talk about the second piece, because the second piece is cost, right? So high quality, fair and reasonable prices. So we're not talking about the lowest cost provider. We're talking about fair and reasonable prices. So we're not looking for.
What's interesting about that though, Rhea, right? High quality does typically end up being on the lower cost side. What's really interesting is that low quality providers can still be the most expensive. That's what I have found so interesting within the healthcare system after seeing some of the data.
Exactly. Do you want me to give you one example?
Sure.
Okay. This one was fascinating. So we had a patient that required hip surgery. We sent them for a surgical consult. He golfed with the gentleman who was an orthopedic surgeon, and he said, "Oh, I'd like to go to him." Sure, no problem. Do you know anything about him? No. Okay. We'll send for a surgical consult, and we're going to look up quality scores. He was adamant about going, so we sent him for the consult only. Remember, we don't order surgery. We order the surgical consult, and then we look at the data to see, because sometimes it's gray, right? The low-level interventions get done first before you go under the knife. Long story short, we looked up the quality metrics of this particular interventionalist, and they were in the bottom 20%. We are not responsible. We in collaboration with our patients, we share what we know and we tell them what our recommendations are. So our physician said, "Hey, we looked up the quality metrics. You do need a hip replacement. That particular interventionalist is scoring quite low. Here's the data that we have. It's not perfect, but it's as good as we've got. We have a high quality surgeon in the top 15% in very close proximity to your home," and showed that data, and then present the data with the risk and reward, right, the benefit, and let them make the decision. It turns out that high quality surgeon was at a facility that charges a bundled rate that was significantly less than the first surgeon who was not going to charge the bundled rate. So the patient ended up making the choice for the high quality surgeon, and we were able to get that particular patient that bundled rate, which ended up being, I think it was a $26,000 claim versus what would have been maybe a $45,000 claim. But the truth is, I don't know, because that's non-transparent pricing.
Yep. Yeah, I know. I have my own personal story too. Unfortunately, I didn't have access to quality, but my dad had my dad had a brain tumor, a glioblastoma. We found out, and this was about 6 years ago. Luckily, I'm married to a nurse practitioner, and my mother-in-law was an OR nurse for a long time, so it felt like at least I had a patient advocate behind me. And we went to he went to a local hospital who was ready to take this thing out, and it's a very rare type of tumor, and there's not a lot of people that do this. Well, my wife did a little research. She found out that this guy's specialty was actually spines, not the brain, and that he does about 10 or 15 of these a year.
Wow.
And we got him into Duke University, who specializes in this, and they do about 600 of these a year. So we immediately felt a whole lot better. And while the outcome, the final outcome wasn't great, what was different is that they refused to operate on him because of what probably would have happened. And we got 11 more months with my dad. And it's partly one of the reasons why I am so passionate about trying to fix the healthcare system is this kind of stuff happens all the time. I mean, I think the stat is that 40% of cancer diagnoses are misdiagnosed the first time around. That's scary, and it makes sense when you don't have access to some of these tools. So, Rhea, you and I have worked on a lot of different plans together. When you take over a plan from a traditional fully insured carrier or traditional self-funded carrier, obviously, your doctors are spending a ton more time now with the patients, and that is the secret sauce. What kind of things are you guys uncovering?
Yeah, I love it when people ask a question like that, because the reality is, because in fee for service, it's not that the doctors are not good in fee for service, it's that the doctors don't have enough time to do the job that they need to do for patients, which is very thorough deep dive. And so what ends up happening is when those patients come to us and we have 2-hour first appointments, 1-hour return appointments, we gather all their medical history, we read, we research, we can go through the entire record. What ends up happening is we find a lot of gaps in care. So usually in the first 90 days, there's a lot of additional healthcare consumption. That's sort of like, wow, now that's interesting. Where is that coming from? Why have there not been mammograms, colonoscopies, imaging, things that are necessary and should have been done had they had good access to primary care physicians and the right amount of time with primary care physicians to do a deep enough dive to go through all of these issues. So we uncover a lot of things. The good news is that we direct them into those services in appropriately priced fashion, so it doesn't cost the health plan, double, triple, or quadruple what it needs to. But what happens in the first 90 days is we stabilize the group, we uncover the things that are going on, and then we basically stabilize them. And so you'll see referrals go up, and then they come down, and then they stabilize at what is considered normal in direct primary care, which is significantly below what you see in fee-for-service. Because with the right amount of time, we can expand what we do. Our doctors practice at the top of their license, which means there's significantly less referrals into the most expensive part of the healthcare system, which is the specialty services. A specialty claim is $500 to $700. You don't have any claims in direct primary care. So keep it in primary care if it's appropriate in primary care. Let your doctors practice at the top of their license. Give them enough time and resources to do that. And watch those referrals in the specialty care services, which is the expensive part, come down.
Yeah, and then you give them a bat line, 24/7 access, and that's where you start avoiding emergency room visits. And we've seen that in every single one of our clients. And I'm excited in the next episode, we're going to dig into some of the utilization details, not just the financial results, but what we actually saw within the data and how people were utilizing healthcare differently. So excited to talk about that. Well, Rhea, we got about 4 minutes left. There's definitely one thing I want to hit on. You know, we talked about patient assistance programs and international outsourcing. We talked to ClaimDoc last week about reference-based pricing and specifically a couple of issues that people deal with in those scenarios, which is not being able to get into your doctor and a potential balance bill. You know, what struck me about your practice was you guys actually understand a summary plan description, what's going on. You understand the solutions that a consultant might put in place to try and save money and give a member a better benefit. Can you talk a little bit about, oh yeah, and that your doctors come to open enrollment meetings, but can you talk a little bit about, you know, how you help employees, patients navigate to some of these different solutions that a broker or consultant would put in place, and then I can kind of talk about the difference in engagement that we see.
Sure. Yeah. It's real simple. We navigate them into the services that you have built into the plan. See, if you turn over the navigation to the healthcare consumer, they're lost. It's very difficult even for us to know where the right places of service are, who balance bills, who doesn't balance bill, who's going to accept the referral. We absorb all of that and we manage all of that for the patient. So before the patient even gets to the dermatologist, the ologist of any sort, we've already made sure that this is aligned, that it's high quality, that the referral is there, that any of the images that they need in order to do the consult and anything else has been buttoned up and packaged and sent through. And then all of that has been scheduled and set up and sent to the patient. So when the patient arrives, all of that's been taken care of, and there's a significantly lower chance that someone at the front desk is going to look at their card and go, "We don't take your insurance," because they don't understand the health plan. You guys build these health plans with these fantastic tools like ClaimDoc and pass-through pharmacies and patient assistance programs. But if the primary care physician at the point of service, when they are signing that referral and sending it out, doesn't know how to use those swim lanes or those services that you've built in there, your plan won't.
They don't even know they're there.
They don't even know they're there. So it's important that we actually navigate into those designs to make sure that the plan functions as intended, the way that you set it up with the plan sponsor.
And that's what I want to stress here, is that not every solution is perfect, and not every employee or member is going to utilize a solution that you put in place. But there's one person that most people trust, and that's their doctor. And if you can arm that doctor with that type of information and you add navigation on top of that, that's how we make problems go away in these types of plans. This is what makes a great member experience. This is how you get an employee to access a patient assistance program where the health plan pays nothing but a small administrative fee. The member pays nothing because we've gotten the drug donated through this patient assistance program. Rhea and her team behind the scenes is how we make this function. This is the secret sauce of a health plan. This is how we get the results and keep a member experience great. Rhea, I know we're close to the end of the time here. Actually, we are. So I'm going to go right here. Everybody knows our final episode now. We're going to talk about this case study. Connect with me on LinkedIn. I have a YouTube channel. Please connect with me there. I put out a lot of healthcare content. If you're ready to schedule a meeting, book it right here. And Rhea and myself, we're going to stick around here for another 15 minutes or so. If you guys have any questions, there's one that I saw come in and I'm going to take a look and see if there's anything else here. Before we get to that, I'm just going to remind the audience one more time. If there's other topics that you want to hear about and healthcare related, it doesn't matter what it is. I don't care if you're fully insured, self-funded. If you want to know about a PPO network, just type in the chat in the questions the topic you want to hear about, and I'll make sure I put some content out about it. But Rhea, one of the questions I got actually is something that you briefly touched on in the beginning, is that have you had any clients that implemented this while they were fully insured?
Yes, we have one fully insured. Now, it's not really cost savings, right? Because you already have primary care baked into that premium, and that premium includes profit for the carrier. So it's a big black box that you've purchased. You've purchased just this premium per employee. This particular employee is fully insured, and they are their guys are on the factory floor. They make vitamins, and every day that they are off the factory floor, they are losing money as a result of not being able to put out the kind of production. And so they did the cost benefit analysis and said, we're going to pay the extra money to pay the PMPM fee to ImagineMD, because it is going to reduce how much time our guys are off the floor when they are sick or they have a healthcare issue. And so for them, they did that calculation and said, it's worth it and we'll pay it. But quite frankly, if you really look at that, right, if you're paying a fully insured premium, you are already paying for primary care. You're going to double pay for primary care. You're going to then add us on top of it. But you need to look at
don't think your insurance carrier is going to give you any credit on your premium for something that you're doing outside of their health plan. It's just not going to happen.
Correct. They're not. Yep. So only one fully insured.
Interesting. You know, that's a good example I didn't think of. I was actually thinking of something totally different. You know, the fact is that I think the reason I run into the most that employers don't end up doing something different is just a fear of change. The status quo healthcare system is all people know, and the fact is that human nature is afraid of change. And so one approach, you know, we've taken in the past with some employers, knowing that that's a reality, is we'll pilot a program like this on a fully insured employer. And that might be 2, 3 people, that might be 10 people, but what that does, and you know, we're looking for people that are going to be champions of this. We're looking for people on the leadership team that can spread a message, because what that does is it starts to build the confidence of the employer that, man, this works. This really works. And then that makes that fear of change go away a little bit and makes the implementation process a ton better. And, you know, that's what happened on one of our clients. I think we had, Rhea, the one that I'm thinking of, our school, we had 3 families that piloted this. And then by the time that they had been in that program for 6 months, next plan year comes around, and you know, basically, with the exception of one person, was a full replacement. Everybody enrolled in direct primary care, and it's a really good way to get started because you get the buy-in from people. I think that's so important as you're talking about doing something different within a healthcare plan. You know, you gotta get people's buy-in. If they feel like they're part of the decision-making process, helps with the successful rollout.
Agreed. I will tell you, one of the other things that I found really, really helpful and where we've seen a lot of success, once we go through the value proposition and the benefit consultant and the plan sponsor and the team sort of say, like, we'd like to do this, but they're scared, right? Maybe you're going from fully insured, maybe you're already self-funded, but you're in a PPO network. And the idea of not having a PPO network and having, you know, switch doctors, it's, you know, it can feel like a lot. Talk to the other plan sponsors that are doing this, right? Go and talk to the CFO, the CEO, the CHRO, those that are actually in these plans and have experienced exactly what it is like to roll this out in the first 90 days, the first 6 months, and the first year. Because you will have confidence once you talk to your peers that you too can do this and see those kinds of results.
Yeah, and I'll say, you know, we have quite a few clients that have done this. And every single employer that we have worked with that has implemented direct primary care has taken that step, and they've talked to another employer that already implemented that. It was one of the biggest things to get over a hurdle. That on top of some of the case studies, that we now have after being in the plan for a very long time. That's what I'm excited to share next week. We've seen some of the financial results, but we're going to dig into utilization, and we're going to dig into where this employer was when we first found them and where they're at now.